We can do a test in New South Wales within, the fastest we can do is about 4 days turnaround. We can do a whole genome, sequencing all the genes, and some of these tests are even Medicare rebatable now. So there's been a revolution in terms of the technology, the time to get a diagnosis, and our ability to diagnose patients.
Hello, I'm Dr. Amit Shetty. Welcome to the Future Health Podcast. This is the podcast about the way we work, the work we do, and how technology will influence the future of work in New South Wales Health and the healthcare industry as a whole. Our guests today are Dr. Alan Marr and Professor Ian Alexander, and we're going to learn a little more about the world of genomics and gene therapies. Both guests bring different perspectives, and we'll discuss some of the considerations we need to think about as new technologies and therapies become more mainstream in the care delivery. I'm really looking forward to digging deeper into the future of work with them. What is genomics all about? Well, we are about to find out more. Great to have Alan Marr and Ian Alexander here from the Sydney Children's Health Network. I'll let you guys just introduce yourselves, and we'll get on and find out how genomics and genetics is changing the way the future looks like.
Okay, I'll go first. So my name's Alan Marr. I'm a clinician and a researcher. I work in clinical genetics at the Children's Hospital Westmead, and I've been doing that for about 10 years now. And I also do research as part of my PhD in genomics. That's...
Okay.
So, Ian Alexander, I'm substantially older than young Alan here, and but very similar. So I'm a physician scientist trained in paediatrics, subspecialising in genetics and metabolic disease, but with a very big research interest, which has grown more prominent as my career's progressed. And my area in research is the possibility of using genes as medicine, so what we call gene therapy.
And looking at the number of years you spend in that, you seriously would have seen a lot of change.
I don't like to say. I started my research career in 1992, so close to 30 years ago. So it's been a long haul, but I've seen genomics and genetics evolve very significantly during that period, and it gives you a sense of what might happen over the next quarter of a century.
Can you give us a glimpse of what your day would have been like 30 years ago and what it is like now, especially in the clinical coalface around how your practice is changing?
Well, Alan's probably going to be better talking about the contemporary situation, but I'm probably better than talking about ancient history. So 25, 30 years ago, the big difference in genomics was we didn't have the diagnostic power that we have now. So that is the most significant change. So very often when we were dealing with children and their families, we couldn't even answer the first question that a parent will ask, and that's what's wrong with my child. And clearly we're in a position now where the advances in genomics are allowing us to answer that question with much higher probability. But there's still a problem, because parents' second question will be, what can you do about it? And this is really where my big interest is, and for me where the future is. But it was that inability to, or challenge in even delivering answers to that first question that I think best characterised genetics 25 years ago.
Yeah, and I'll bring Alan in now to tell us how is it at the coalface.
Yeah, so even in the last 10 years, things have changed a lot. So 10 years ago, when I first started my training and doing clinical genetics work, we would it was very much seen as a rare disease, very niche area where we would diagnose patients clinically and maybe order a single genetic test overseas, costing thousands of dollars and many, many months before we got a possibility of an answer. And so the vast majority of our patients remained undiagnosed. And now this is leapfrogged in 10 years' time, where probably the majority of our patients now have a genetic answer. We can do a test even in New South Wales within the fastest we can do is about 4 days turnaround. We can do a whole genome, so sequencing all the genes, and some of these tests are even Medicare rebatable now. So there's been a revolution in terms of the technology, the time to get a diagnosis, and our ability to diagnose patients. I think at the same time as this technology change has come, there's been a much broadening of who can do this genetic testing and genomic testing. And so it's been mainstreamed out to not just geneticists, but neurologists, pediatricians, even in primary care, GPs can order a genomic-based testing to screen couples before they plan a pregnancy. Obstetricians are ordering this during pregnancy. So there's been a kind of dissemination of the ability to do genomics away from just the realm of clinical geneticists and pediatrics to a much broader kind of category of different clinicians. I kind of like to think of it as it's kind of like when MRIs first came out, that they were only ordered by neurologists, and now we have surgeons ordering them and GPs ordering them. So it's that kind of technological revolution.
Yeah. You raised a very important point there around what patients want. And do you see that driving the growth of this area much more than it used to in the past?
Well, I think what families want and what people in the health sector want tends to be the same thing. And so they want the answers, the diagnostic answers, but then they want to be able to do something meaningful with that answer. And there are meaningful things we can do, and in some conditions, finding the diagnosis is the key to immediate access or very rapid access to an effective therapy. But for many, that's not the case. So I think the fundamentals of what is wanted is shared between healthcare professionals and the people they serve.
How do you see this being playing out into the future? And do you see this, because like many things, there are always bright spots and then dark areas. There are some certain places where the progress has been significant, and then you can see, almost have a glimpse of what the future could look like.
Yeah, I think it's tantalizing how much this is going to impact health. I think there's also challenges. So one of the biggest challenges at the moment is this technology is really advanced, but it's advancing faster than our education of clinicians can advance. It's advancing faster than society and ethics are still catching up on how we can handle this type of technology and what we should be doing with it. And it's expensive as well, so funding issues as well. So there are big challenges, but I think the opportunities that it could unlock are actually probably worth that challenge, facing that challenge, and also could potentially have a lot of impact on general health as well. So I guess that mainstreaming theme you could see in terms of the benefits of genetics as well. It's not just for rare conditions, but possibly in the future it may unlock our ability to help with more common things. So working out risk factors for common diseases, or pharmacogenomics, where we alter drug doses based on your genetic profile, all the way to screening on a population level. There are lots of challenges with all of that, but potentially it could unlock a lot of benefits. On the rarer diseases or genetic disease front, there's the opportunity for gene therapies that will be coming and is already happening in some fields. And I think that's something that Ian's very, very involved in, and something that's very exciting, that offers a lot of potential to benefit a lot of people.
Yeah, and I'll bring you in there because, as you highlighted, it was interesting when we started doing medicine. It was all about diagnosing, making management plans, and introducing those management plans. And that is where you highlighted the gaps still are around diagnosing and managing. In those scenarios where you do have a gene therapy now becoming available, can you see how that changes, and how can you share a story where you can probably highlight how it has changed significantly and what it is looking like?
Yeah, no, we have a very good story unfolding here in Sydney right now, and that is around a rare genetic disease affecting infants called spinal muscular atrophy, or SMA for short. and this is a condition where infants are born healthy, but very quickly, in the severe form of the disease, motor neurons are the nerves that supply muscles start to die. And this takes these poor infants and their families on a terrible downward journey, with the infant usually succumbing between 15 and 20 months of age. And so this is a condition that historically, and certainly when I was a younger physician, there was nothing available. So this was, you would make the diagnosis and then really could only offer the family support. But now there's two therapeutic modalities. One is a synthetic oligonucleotide. I won't get too technical, but that does significantly slow or even halt the disease progression, but it's a therapy that needs to be given recurrently, so you have to redose the patient at intervals. And now there's a second option, which is gene therapy, and this is actually delivering a healthy copy of the faulty gene to the patient as a one-off intervention, and what we're hoping will be a lifelong cure. And this is done using a genetically engineered virus, believe it or not, to carry the healthy gene in. And there are now over 300 children globally that have been treated, and quite a few locally. And there are infants running, or children, small children running around, walking and talking and developing within normal boundaries as a consequence of this new therapy. But this is just the beginning of a new era. So we're really just at the dawn, and we have, even with that therapy, it's not a mature therapy. There's a long way to go, but it's an exciting exemplar of the world that lies ahead of us in terms of not only therapy, but other ways of dealing with health problems that include, of course, prevention.
And as a clinician on the workflow, how does that fit into your daily schedule or when you see patients in your clinics? How does that impact you?
Well, it's very exciting because I think for a long time we had very little hope to offer for these families and patients. And even for the first few years of my training, there was nothing available. And so we would see regularly patients die from this condition every year. I think it offers hope and possibilities of more than what was previously available. I think it's also unlocked, I guess, the terms that we use around this are things like precision medicine or genomic medicine. It's kind of giving us a hint at the potential of what this technology can do. There are also flow-on effects that affect our daily clinical practice. So even though spinal muscular atrophy is pretty rare, 1 in 40 people could be carriers for this. And so then that asks the question, well, should we be screening people for this if 1 in 40 people are carriers for this? And it's recessive, so if a carrier has a child with another carrier, there's a 25% chance that their child could be affected. And so one of the flow-on effects of this therapy being available is now that in New South Wales, spinal muscular atrophy is on the newborn screening card. So on day 3 of life, every baby is screened for SMA, and also we are now routinely offering screening to couples before they plan a pregnancy. They have the option to have this type of screening to know if they could be carriers for this, and up to hundreds of other conditions that are similarly severe as well. So it's kind of unlocked a lot of potential in terms of what genomics can offer, but also I think ultimately, though, the aim really should be to offer treatments and therapies and options for people beyond just a diagnosis.
What you share there is clearly a very bright but also scary perspective on almost a shopping cart kind of view of how we're headed. Could you just share a couple of things you think how it could go really well or really wrong?
Yeah.
And then I'll bring you in to see what we need to do in the next 30 years to make sure that we get the best out of this beautiful scenario laying ahead of us.
Yeah, I think that, like I mentioned before, there are big kind of ethical and societal and economic implications of this technology. It's not cheap. It is getting cheaper by the day, but it's not cheap. And the therapies are definitely not cheap. But I think as long as this is rolled out in a way that's equitable, that gives people choices. It's not about coercing people to have a test or be screened or things like that. It's more about giving people options to maximise their health and the health of their family and their future families as well. I think if it's framed in that way, then it has the best potential benefit.
Yeah, and in ENU, how do you see this being done in a right and ethical manner and being able to deliver what we promise we want to?
Well, I think we're still navigating a complex path, so I don't think anybody's got a complete and comprehensive answer. I think we're all working to a guiding set of principles about making sure we do things ethically and equitably, but we also want to work very hard to deliver the benefits of the genomic revolution to Australians at the earliest possibility. And there's tremendous challenges in that, and many of them are scientific, some are logistic. There are a lot of issues around health system readiness that we're addressing, and certainly these things have been given a lot of thought, say within Sydney Children's Hospital Network, where Alan and I come from. But the other thing that we need to be realistic about is that Australia's not a very big country. We do about 3% of global research and development. So even if we're punching at or above our weight, we can expect that at least 95% of these new therapeutics are going to come in from overseas. And at the moment, we're facing an avalanche of clinical trial activity. And not every one of those clinical trials is beneficial to our patients. So one of our early challenges is to, particularly as clinicians who look after particular cohorts of patients with particular conditions, is to navigate their way through the possibilities of what should the patients and families that we work with, what is going to be good, and clearly we don't want to be paternalistic about that. We have to share the possibilities.
The last time we spoke, you had a very succinct way of addressing the ethical issue of clinical genetics and gene therapies around germ cell line and semantic lines. Could you explain that just quickly, and then we can...
No, it's very important, Amit. So there's tremendous ethical challenges ahead, but within the gene therapy space, some of the ethical concerns people might have do melt away if one understands that what we mean by gene therapy is somatic cell gene therapy, not germline gene therapy. And let me just explain that in a very accessible way. If you have a child with a liver disease, for example, if we want to do gene therapy, we would just correct the faulty gene in the liver. We wouldn't be touching the cells in that child, whether they were sperm or eggs, that are going to influence the next generation. So we would cure that child of their condition, but we would have no impact on the human genetic blueprint, if you like, that gets handed on through the generations. So that the latter, if you were going down that path, and there's actually no practical reason to do it, even though it's something that we wouldn't consider doing ethically, if you understand that, a lot of the ethical concerns melt away. So it's not really different to any other therapeutic modality. It's for the individual, and it has no broader implications for the human genetic blueprint or genome.
All right. Sounds good. Any burning point you wanted to make which you didn't get out, you think? Or
I think one thing I mentioned before was about, when we talk to families, we can now offer a bit of hope.
Yeah.
I think it's still really tricky though. And I think there's a lot of hype out there as well. There's a lot of over marketed expectations about things. I mean, it's really hard to have that balance with families, especially when they're impacted by a severe genetic condition. I think the future is still looking hopeful, but what we can offer now, it's hard to predict what we'll be able to offer in the future. There will be therapies available in blinding conditions, in other cystic fibrosis. There are already things happening, but the exact impact of this on the future is uncertain.
And maybe one or two comments about workforce, because obviously Alan and I are a part of a workforce, and as I look back at my own career, perhaps, I can see that I've had to adopt a posture of sort of lifelong learning. and be adaptable. And I think one of our big challenges at the moment, and Alan's already talked about mainstreaming, but we want not only to get the genomic message out to the workforce, but we want the genomic workforce to be very adaptable and pervasive through the whole medical system, as Alan outlined at the beginning. And of course that has implications for how we get trained as well. And I see the need for us to all come out as, I was going to use a medical terminology, but like a stem cell that can differentiate in a whole lot of directions and then de-differentiate and go in another direction. And you'd like to think that we don't put such rigid structures around our training that people can't move in across disciplines and cross, fertilise and cross-pollinate. And I think that's the way to move forward, but it's not necessarily easy to achieve.
And you're seeing the need for that even during this crisis, of just having specific specialties and special paths. But
Exactly.
I think, I
Exactly.
totally agree with
hear
you.
the word pivot.
Yeah.
We all need to be able to pivot individually and collectively.
Yeah, that's true. So how do you see the future workforce do better genomic medicine?
Yeah, I think I touched upon this a little bit, that the technology is advancing so quickly that things like textbooks and curriculums and training programs are probably not keeping up with the way that this is advancing, and that's an area that I'm involved in genomic education. On the other hand, because the technology is so good and improving, our ability to automate the technology and use it to just generate information, reports, diagnostics is probably going to improve as well. What I often say to trainees who are interested in this area, or even training in other areas of medicine, is they do need to arm themselves with this information. It's kind of like what Ian said about being a self-directed learner. This is something that is probably going to be mostly on the latest online education modules, journal articles. This is kind of breaking news, really. So it won't be in any of the textbooks. And so I think it's really important that people arm themselves with this education and information. It is slowly disseminating into the public and into school education as well. And I think one of the interesting things I've noticed is that many years ago, when I talked to a patient, they would just want to know whether they can have a test for their condition. These days, when I talk to patients, they want to know if there's a therapy for their condition. So that it's out there in the social kind of psyche that that there are gene therapies coming. This is especially true for the eye genetic patients that I see. They are often asking about this, and I see that as a good thing, because I think the more the community knows about this and is aware about this, the more that they will want this, and it'll just become a normal part of medical practice, that a lot of this is being driven by society and societal expectations, rather than by the doctors or the pharmaceutical companies So I see it as a good thing. But again, like I said before, it's kind of managing that hype is tricky. In terms of a future workforce in this area, it's interesting to think that I started my training to diagnose patients with genetic disorders. That's rapidly becoming automated and being done by many other clinical areas. Maybe in the future, geneticists will be involved in treating these genetic disorders or advising management of these genetic disorders. And I think that's a big change in our mindset of how we work and how we think about work. And it's also going to be a big change in many other clinical areas, probably more than we can imagine, in terms of people thinking about genetics and genomics as just a normal part of their conversation with their patients. For example, a GP taking a family history and thinking about genetic screening.
It's almost like bringing because this is the part of the patient's history. The genome is their part of their history, isn't it? And I hope someday in the future the orthopedic surgeon will be ordering the genomic test too. Ian, what were your thoughts on that?
Well, I agree with everything that Alan was saying. A fundamental ingredient in all of this in the future, to my mind, is communication. And I don't think we in the medical profession and the healthcare professions have historically done a very good job in this space. And I think we've often underestimated the ability of families and the community to absorb complex information if it's delivered with great clarity and you distill it down to its essence. And so I think that we can bring our colleagues and the community along if we not only do all the things that Alan is talking about, but we work very hard on clarity in our communication and be very ambitious about sharing information. And I think we're seeing this globally. You used to hear people saying, oh, you just need to speak in sound bites. And now we're discovering people are enjoying sitting down and listening to podcasts that are sort of long form and last an hour. And so I think, we've got to recognise that the community is capable of taking a lot of this on, but our challenge is to do the communication.
Alan and Ian, thanks so much for a great conversation. There's so much you could go on about, but that's all the time we've got for today. Hopefully we can continue the conversation into the future sometime. Thank you very much.
Thanks very much. We enjoyed it.
So that's all we have time for this episode. Thanks for joining me on the show. If you enjoyed the podcast, make sure to like, share, and subscribe on whatever platform you are on right now.